Hey guys, it's your boy Mustuts, back with another Mustut. Let's get right into it. The ECG case for today is the ECG of a 69-year-old gentleman, smoker with a 50-pack hair history who presented with typical chest pain and diaphoresis. These were his initial ECGs. We have our standard ECG, we have our V4R, and we have our posterior leads. There are two important abnormalities. See if you can spot them. Let's go through it. So first we'll look at the rate, and we can count the number of curious complexes, which is going to be 6, and we times it by 6. Why? Because it's a 10-second ECG, and that equals 36, which means that this is a bradycardia. We can also see just from the eyeball test that this is a regular bradycardia, right? So typically when we talk about bradycardias, we need to think about sinus bradycardia, AV node blocks, and SA node blocks. And with our AV node blocks, we talk about first degree, second degree Mobitz 1, second degree Mobitz 2, and our third degree AV blocks. We'll have a quick recap of the AV blocks. So with our first degree AV blocks, you've typically got a constantly prolonged PR interval that is more than 5 small blocks with no dropped beats. With second degree AV blocks, Mobitz 1 or our Wenkebach phenomenon, you've got a progressively prolonging PR interval with drop beats. It's almost like giants' footsteps walking throughout the ECG. It's important to note that the PR intervals start short and they get progressively prolonged until you have a drop beat. With our Mobitz 2, you have a constantly prolonged PR interval. So let's say it's 7 small blocks, and that PR interval will remain 7, and then you'll get drop beats every so often, right? Third degree heart blocks are going to be the focus of today. So let's just go through the conduction in the heart. You've got your SA node sending impulses down to your AV node, and then you've got your bundle of His with your left and right bundles and our Purkinje fibers, right? So with the AV node, a third degree AV node block, you've essentially got this AV node that is just not working. So my best friend is not conducting anything through him. So what happens is the atria do their own thing independently of the ventricle. So they are dissociated completely from one another. And remember I spoke about the heart wanting to follow the leader. So the atria typically still follow the SA node, who is still the leader. But those impulses are not able to get to the ventricle. So the ventricular cells decide, okay, we need a new leader. So you can either have a group of myocardial cells that are just in the specialized conduction tissue, and we call it junctional escape, or within the ventricles, and we call that a ventricular escape, right? Generally, junctional escapes are going to cause narrow complexes. Why? Because they're using your specialized conduction tissue, whereas ventricular escapes are going to go from one myocardial cell to another, and that causes broad complexes, right? The important question is why do we get third degree AV blocks with inferior MIs? And this is because the AV node, nodal artery, is a branch of our right coronary artery in 90% of people. And remember that inferior STEMI is the most commonly associated with clots of the RCA, generally in RCA dominant circulations. So let's see, do we have a third degree AV block here? So we're going to trace out our P waves. So we've got a P wave there, we've got a P wave there, we've got a P wave there, one there, one there, one there, one there, right? And if we go back, we can actually see that those P waves are completely independent of the QRS complexes. They have nothing to do with the QRS complexes. And if you count them out, there's actually 19 P waves in this ECG strip. And that means that the atrial rate is actually at 114, whereas the ventricular rate is sitting at 36. So important to note. The second abnormality in this ECG is actually ST elevation. Remember, this is a patient that presented with a chest pain, so we need to look for ST elevation or ST changes. So we can see by starting off with the inferior leads, which are 2, 3, and AVF, that you've got ST elevation at the J point of above 2 millimeters above the isoelectric line, right, which is this line over here. Right, then we can look at our anterior leads V1 through to V6, and we can see that there's no ST elevation, but rather ST depression. Then we can look at our high lateral leads, and we can see that we've got quite marked ST depression, especially in AVL, but also in standard lead 1, right? Then we can look at our V4R, right? And we're going to look for ST elevation at the J point, which we actually don't have. Next, we look at our posterior leads, which are V7, V8, and V9, and we're going to try and assess for ST elevation at the J point, and we can see that there is no posterior MI. So to put it all together, this over here is an isolated inferior MI with reciprocal ST depression in your high lateral leads. Remember, likely RCA dominant. Why? Because the degree of ST elevation in standard lead 3 is greater than that in standard lead 2. So if we measure that, ST elevation is greater than that. Secondly, you've got ST depression in AVL, right? You can see that ST depression. And then you also have AV nodal dysfunction, which typically happens with our right RCA dominant circulation, right? So a few points in management. One, unstable bradycardias are dangerous in patients with STEMIs. So you can treat with atropine, but remember the AV node dysfunction is not mediated by parasympathetic influence. It's rather due to poor perfusion of the AV node. So the more important goal is to restore circulation or perfusion to the AV node, and in doing so, hopefully reverse the third degree heart block that we have. Second is to have your transcutaneous pacing leads ready, because these patients become unstable, you may need to pace them. And then third is to lyse with alteplase over strep. Right, so with modern adjuvant therapy of STEMIs, alteplase has a higher achievement of coronary reperfusion and flow versus streptokinase. It is, however, more expensive, but has a low risk of bleeding, and it's generally more stable in these patients with inferior MIs.